Hey, welcome. Hi. Whoa, I never remember my microphone. What's the matter with me? Okay, I hope you can all hear me. We're experimenting today. Not the case is an experiment. We'll talk about a good case, but I'm playing with lights. We ordered a new camera. This is not the new camera. This is the old camera. We'll be broadcasting through a different system probably by next week. So the thing's in flux, and if things get screwed up in the middle, I'll make it up to you. I think it's going to be okay. So, hi, it's February 19th, and thanks for joining us. We'll talk to you a bit about the anterior case. And the anterior case, that makes a big deal. It's front teeth. People don't care about back teeth. They care about front teeth. Yeah, I know they care about back teeth for chewing, but you know what I'm talking about. First, how are you answering your phone? How is your front desk answering the phone? It's probably one of the biggest problems that we see as we're going out and working with our clients, and that's answering the phone. Okay, so what happens if somebody calls your office and they ask you, do you do endo? What does your front desk person say? Okay, and it might be the same thing. Do you do crowns? What does your front desk person say? And the answer has to be the patient is calling you, and the patient should be coming in to see you. And then you come up with the solutions to make that happen. And that's probably, if we look at in the IDS and our consulting, the two biggest areas are organization of schedule and how to answer the phone. Those are the two biggies. Yeah, there's staff things as well, but staff organization certainly is probably number three. So if you're not working on answer the phone. If you think there may be a reason for training, then talk to us, or just join the IDS. If you join the IDS, you've got access to library, training library. And so there's a professional library, so you can start to look at training your own staff on a do-it-yourself basis. So think about that. In the meantime, let's talk about the anterior case, and let's see where we're going with that. And okay, first thing I have to do is learn how to share my screen using this new system now. Let's see how we do. I hope we do it correctly. I think it's going to be okay. All right, good. I hope you see it. Okay, inadequate room for restoration of the anteriors. So let's first of all, we want to thank the Oral Reconstruction Foundation. The Oral Reconstruction Foundation provides you the CE credits. Allison Davis is fantastic. Probably by Tuesday every week, you get your CEUs. Some people may be wondering, why don't I see CEUs? And for those who attend for a short period of time, can't do it. If you attend for most of the session, then I do it. And of course, I can keep track because I know you've registered through Zoom and I know how long you've been here. So nobody's asked me about that. So, but if you're curious about that, that's how that works. For those who want to come on board, just go to directorofdentistry.com. And right on the home screen, you'll say, please sign me up for the free material. Sign up for the free material. Then you get onto these webinar, you get the advertising for the webinars, which comes out usually, I try to get out Sunday just to remind you, and Thursday to let you know what the case is all about. So let's talk about this case. We get the intake call, and Kathy takes the call. His partial denture broke. He has a temporary fix, but would like us to see if we can repair it or replace it and what his options are. He's up to date on his prophies. He has no other issues. Okay, so there's no time for doctor call. He actually calls on, I think, on Tuesday, and we saw him on Wednesday. He called on Monday. We saw him on Tuesday of this week. So we do see him, and he has no allergies. He's 58 years old. He wants to see what his options are. Blood pressure is a little bit high. And that's where he is. That's with his flipper in place, as you can all tell. So that's how the flipper is working. And that's his occlusion with the flipper out. Now you'll notice a few things. We'll go into it a little bit, but you notice the fixed bridge, or there was a fixed bridge, from number 6 to 11, and you notice there's no fixed bridge anymore. Okay, the bridge fractured. There he is. We open the bite and just take a look at it because we're going to talk about this in detail today. No more severe periodontitis. We're going to talk about restorative dentistry, which is going to very much tie in to periodontics and dental implants in particular. So, but remember, people are here to chew, they're here to smile. And there may be some compromises here as far as how much this person can chew and smile this way. He obviously bought a fixed bridge for a reason. Okay, so there's the occlusal view on the upper and on the lower. Okay, y'all have a picture of it, see what that's all about. Okay, so let's continue. And let's look at the full mouth series, and we'll just go through it in detail. You'll see there's very little in terms of perio issues. In fact, I don't think there's any perio issues at all. So I know I was a little bit fast going through this last week. Let's see if this is a little bit slower. You'll see the little solder joint, welding joint, whatever was it that fractured. You can see that in the mesial of 6 now, number 11. You go across, things are looking pretty good. Bone levels are pretty good. Go on the lower, maybe see a little bit of a defect in the distal number 18, but it's no biggie. And we go across. And here's where we stop for a little while. Just take a look at tooth number 25. Okay, so tooth number 25 is that endo. His history is that he was involved in a traumatic incident when he was 16. And so the trauma occurred on his lower front teeth and his upper front teeth, and the upper front teeth had to be extracted. So that's 16 years old. Now he's 58. Notice an open margin on the distal aspect of number 6. Let me see if there's anything else I want to show on that. Nope, I didn't record anything else. So let's move on. So take a look at that. What do you see? What bugs you about this the most? All right. What should be bugging you and what's bugging me is why that bridge fracture? What was it about the bridge that made it fracture? And also take a look at that right there. Remember, we were taking a look at the radiolucency, and we saw cement or something coming out the side of the root, on the distal side of the root, number 25. Okay, he doesn't even know he's getting drainage there. At least I don't think he remembered he was getting drainage there. But that's a constant source of infection. Okay. What else? So there's his partial denture. And the first thing he wanted me to do was to send it for a laboratory repair. He said he got an at-home kit, and maybe you've heard of it. He got something called Bondic, and he fixed it himself. And I'd never heard of Bondic before. You may have seen infomercials that I haven't seen before. So let's look at Bondic. And I know you're not here for infomercials. So there's Bondic. It works best on rough surfaces and even better with undercuts. It solidifies only by exposure to the included UV light. Bondic works best in layers. The maximum thickness of one layer is 1 to 1.5 millimeters. Bondic works best when the surface is clean and free of grease. Bondic contains no solvents and will never dry out. Bondic is a liquid plastic welder that should be used with the Princey. I don't know what the rest of it is. But I'm sure you have to keep it dry. So it's not glue, it's plastic. So he said I repaired it with Bondic. And so while he was there, I said, let me see what Bondic is. So we went to the website and we saw this. So there's Bondic. So we're repairing a cord. We put a UV light on. how do we do fillings, for Pete's sake? Right? So we're going through this, and yeah, okay, let's repair a fob. Let's get that fob working again. And good, it holds its keys again. Oh, let's take the gear that our kids, where the toy broke. Let's repair the gear. Oh, good, let's put it on there. Oh, it works perfectly now. How about this? You're concerned about mouth fluids, about saliva? There we go. All right, and now the drain runs free and clear. What do you think? Yeah, you break your glasses. You know the whole story. So put on Bondic. And you fit the two pieces together, you do the UV light. Isn't that amazing? Yeah. That's Bondic. Now for $25, you can pick up Bondic and you can do this. I can't repair that part. He said, can you send it to the lab for better repair? I can't do a better repair than he did. It's plastic. It's not like he's putting super glue in there. So I said, no, to save your money. It doesn't make any sense for us to repair the partial denture. You did a good job. You got acrylic against plastic. So you got acrylic against acrylic, essentially, and or plastic against plastic. And that is Bondic. So I'm ordering some Bondic for the office. Who knows where we can use it? And then for $25 on Amazon, maybe it's 26, whatever it costs. That it's so if I've helped you and I've given you the benefit of an infomercial, that's great. So there's the perio chart. No big deal. You've got some problems a little bit on, on the palatal aspect of numbers 12, 13, 14, 15, little pockets, but some of that is palatal thickness, just thick tissue. Maybe there's some subgingival margins there, I forgot, but certainly not a significant periodontal case. So let's take a look now at the CT. Okay, we'll just run across. I don't think you're going to find very much on top. Yeah, there's a little bit of a density within the maxillary sinus, but there's no endo problems that we're seeing. So maybe a little polyp, who knows? Go across now and looking at the thickness of the bone here, and the thickness of the bone. So the buccal lingual width is what, 4.67, I think that says. You can see it better than I can. Oh no, I can see it on my screen. All right, and now we're in the number 8 area, it's 4.74, so it's a little bit too narrow for placement of an implant, at least the crest, but we go deeper, 7.11, and that's the number 8 area. Let's look at the number 9 area and see what the width of the bone is there. 4.67, okay, we go a little bit higher. Yeah, 8.07, good, that's the number 9 area. And let's go to what we estimate is the number 10 area. And let's look at that, 4.88, a little bit narrow. But if we go higher, it's going to be wider again. So let's go all the way through. Let's see what else. No, there were no deep substantial margins, numbers 14 and 15. Those teeth haven't been restored at all. So we've got some thick tissue or maybe a small perio problem, but certainly nothing to write home about. So let's cross the lower, and we're going the lower left. We're going towards the anterior, or number 20. Now 22. And 23, 24, 25, we start to see those problems. There's the number 25 with the attempted endo repair, and it was a good attempt, but he's got external resorption, or perhaps it was internal resorption that broke through. I don't know. And then we all go all the way through. All right, good. So I don't know if there's anything else we highlighted there. Did we? Yeah, I think we did. Yep, we did. So let's go over to that area. I record this in advance so that. Okay, so you'll see there's no pulps. No pulp at number 24. Take a look at how close the lower incisal edges to the upper ridge is 5.53. And there's 3 millimeters of tissue. So it's 2 millimeters away. And in the incisal papilla area, it's a lot less because the incisal papilla is coming down. how much room do you have to restore the upper teeth properly? You don't. Why did the bridge break? Because there wasn't enough room. And there was too much force coming from the lower incisors that eventually broke the weld of the tooth. Make sense? Sure. So let's take a look at that again. And you see how close that is. So that if we're looking at, let me get a little a drawing instrument here. Yeah, here we go. So if we're looking at that area right there, how are you going to restore that area properly? With a fixed bridge? With dental implants? Can't do anything with it? I can't. Now, there was an attempt made to keep the lower teeth. But look at how wide the span is of the bridge. You can't see number 11. You can only see number 6. We wouldn't build anything that way. We wouldn't build any house that way. But sometimes we say, well, we want to save the patient's money. They can't afford to do it the way we want to do it. And part of that is not they can't afford to do it, although that happens for some. Part of it is a patient understanding why it's necessary to do something about the lower teeth in order to be able to make the upper teeth work. Is there any way we're going to be able to make the upper teeth work this way? Yeah, with a temporary partial denture, which will continue to break. There's only so many Bondics you can do. And if that's all he can do, then that's where we start. I mean, that's where we stop, not where we start. So we look at this, this joint, okay? And the strength of the joint very much determines the success of the bridge. The thickness and the anatomy of the contact in a posterior tooth very much determines whether the patient is going to get food impaction or not. But in a bridge where you have very, very short teeth, there's no room to put in a joint that's strong enough that won't break. Now, you add this plus a huge 4-unit Pontic site, and I'm belaboring the point. You get the idea that how is this bridge going to survive? And it did survive. I forgot for how many years, but it did survive. But it's certainly not something that would have a long-term or a lifetime survival. Not that anything lasts a lifetime, but there's really no good way with the forces that are here to create a bridge that's going to be adequate and it's going to be strong. And frankly, each of these canine teeth are going to be jeopardized. You know, a bridge is only as strong as its weakest link. In this case, the weakest link was what? The solder joint or the weld joint, or the casting joint. But other than that, you've got a very short canine tooth. What else could happen? If the joint were good, what's the next weakest point? It could be the tooth. It could be the margins. It could be that you'd get leakage. And so we've got to consider all of these when we're designing a case, right? So there he is. And we look across here and we see here's the ideal incisal plane that we'd like, right? We want to flatten everything because we want to have enough room for teeth on the upper arch. And by flattening the teeth to this degree, then we'll have enough room for teeth on the upper arch. But what happens if we just flatten the teeth this way? Well, in this case, we probably have 4 dead teeth, as we could tell from the X-rays. So you could probably cut the teeth off this way. But let's assume we had healthy teeth. What could we do? We could cut the teeth off this way. We could do root canals on all 4 of those teeth. We could then do crown lengthening, but you have relatively short roots, and then you can crown all 4 of those teeth. Is that a good treatment plan? What do you think? Okay, I know I can see you shaking your heads. Okay. So there are the teeth And that's the desire. That's what we want to do. If these teeth were healthy, what's our first step? How about going to the orthodontist and asking the orthodontist to do this? An orthodontist can do intrusion. You have healthy teeth on the bottom, in the posterior. Orthodontist can intrude these 4 teeth. It's the first step. And now look at the amount of room that we've created in the upper arch. Now we've got a better chance for good forces, right? So if we take a look at the lower again, just to refresh your memory of what's going on in the lower. We've got that. So we've got the lucency here. We've got the lucency here, likely dead pulps. This you can barely see. I'll outline it in a second, but you can see what I'm outlining right there. But there's some kind of a defect, perhaps resorption within the root itself. But that dark area is a significant area. Okay, so there's the lucency, no pulps, and some kind of apical lucencies on each of those teeth. They're not good enough for us to treat. They're not good enough to work with orthodontically. Oh, I suppose you could try. You can try anything. But with a draining abscess coming out of tooth number 25, where that circle is, you going to do anything with that? No. Okay, so while we may go to the orthodontist for healthy teeth, for diseased teeth, the only choice we have is what? Extraction of these 4 teeth in order to get the teeth in the correct position. Now let's just take a look at upper implants. So here I did an anatomized design and I put in 2 implants. So when I went across, I found the best place for implants was in numbers 8 and number 10. So there's a number 8 implant, and that went in pretty well. He's got good bone, and the width is good. I used a narrow implant there. That's the 3.0 implant. Okay, so you can see the implant in place. So you see the purple arrow, and then you see the implant in its profile within the bone itself. We look at number 10, and the bone's quite a bit thinner there. Okay, and you see the concavity that's going on right here. So I'm not happy with that kind of a concavity. And frankly, as we looked across at the bone when we were looking at the original CT scan, the bone was a little bit narrow. And I don't want to have a risk of of loss of bone support in that area there. Neither do you, right? So what do we want to do? Well, we certainly want to do a surgical guide in order to be able to design the implants in such a way the implants correlate with where the teeth are going to be. And then at the same time, we'll do a bone graft here, and we'll move the bone graft. And I'm obviously not going to do a bone graft just in the 1 area, in the number 10 area. We're going to do an area graft. That's the only way you can do a graft. I'm not telling you anything you don't know. In order to build that area out, but we can place simultaneous implants. Now we'll do more of a diagnostic wax up, or at least a virtual wax up, to be able to determine that. But we can put implants in likely and develop the bone graft all at the same time. Patient can wear an Essex appliance while that area is healing. And that's a good thing. And the Essex itself is relatively inexpensive. And the Essex doesn't hit the tissue like the flipper does. And so the Essex will allow the bone graft to fill in without any impingement of the prosthesis on the bone graft itself. So we use Essex appliances a lot. We make them right here. It takes a little bit of laboratory knowledge, but not a lot. And so we can give the patient something that's worn here. If they break, they're relatively inexpensive to replace. Well, let's take a look also at the position of the teeth. So now if we just make these teeth this length, which is about the length that we'd expect the teeth to be in order to be able to get the smile correct, in order to be able to get everything the way it should line up. Did I miss something? I sure did. So let's try again. No, I missed it. Come on. Let's try one more time. If it doesn't work, I will not make you watch this again. There, that's what I wanted. So you can see the depth of the overlap that's here. So if we put implants here, the implants are going to be traumatized quite a bit with those lower teeth in the current position. It's just one more thing to show how we would need to do something else. Now, would anybody here choose a fixed bridge? I think if we were to choose a fixed bridge, we'd have to double abut it. Number 5 and 6, or 4 and 6, if there was ortho done. 4 and 6 and 11 and 13. You could do that. I don't know that I would do that, because that's a very, very, very long span bridge. And if that bridge is affixed to 2 teeth on one side and 2 teeth on the other side, where's the weak point going to be now, particularly if we adjust the lower teeth properly? It's usually going to be in one of the abutments. And so when you make a bridge that's this big and you leave it in for a long enough period of time, when you have a bridge fitting over 4 teeth at one time, chances are a cement washout is going to occur, and you're going to get decay in one of the teeth. Okay, the forces here are that way. The span is that way, and even with the scanning that we do, even with the scans that we do, they're still not. They're accurate. They're much more accurate than anything we've had before, but they're not 100% accurate, and the chance of a misfit is pretty high. So the chance of a failure of one of those teeth down the line, it won't happen right away, is pretty big. Now, look what happens on the lower when we extract the lower teeth. We remove some of the bone in order to be able to place the implant at the correct profile. And now we have the lower tooth hitting the upper tooth correctly. Now we've created some room. And now we have the opportunity to restore this patient with implants on the upper anterior, implants on the lower anterior, not touch the natural teeth at all, and let the natural teeth do the work that they were made to do for themselves. They don't need to support front teeth. You know, we have bone in the front that can support the front teeth, and we take the stress off of the back teeth. Would we repair the canine teeth? Yeah, sure we would. So let's get off this for a second. So yeah, we would certainly replace the canine teeth with new crowns. What else would you do? You might want to bleach first in order to be able to get the teeth as light as possible, in order to be able to create the opportunity for good aesthetics before you do this crown and bridge. As a specialist, and many of your periodontists here, you can plan this entire case. And with some of the treatment planning softwares we have, we can tell the story pretty much like this, and give the patient the opportunity of understanding why it's worthwhile spending the correct amount of money in order to be able to do this right. Okay, you can do it. I'm working with a consultant now in this new broadcast facility, so we're upgrading here. He said, buy it. His slogan is buy it right or buy it twice. Buy it right or buy it twice. That's where we are here. Buy it right. Do the design from the teeth up and the teeth down. And your patients, and this patient, will have the opportunity for a fantastic lifetime restoration, not put stress on the natural teeth that were never made for that kind of stress. Have a smile that works, won't have to use Bondic anymore, and will be able to chew and smile and be able to function confidently. Hey, this is a short one today. It's 12:29. What kinds of questions? Anybody have any questions? Anybody have anything, any comments that you want to make before we end this session today? All right, there being no questions, I appreciate you joining joining me. We'll be back together again next week at noon Eastern and at 9 a.m. Pacific. Thanks. Have a great week.